Hi guys, so I'm in a little bit of a different spot again because I just want to kind of see where it's best to film. But today I am going to be doing a giving Remicade video. Hey guys, so I realized as I was editing the video, I never said what Remicade was or what it's used for, which I think is kind of important if I'm making a video about it. So Remicade or infliximab is a type of infusion that treats different types of arthritis, psoriasis, and Crohn's disease, which is what I basically focus on in this video. It works by blocking the actions of TNF, tumor necrosis factor, which helps relieve symptoms of inflammation and reduces our immune systems, basically. The reason we have these types of diseases is because our immune systems are in overdrive, attacking the healthy tissue that we have. So this is why it relates to tuberculosis, which I mentioned later in the video, and we'll get into that, so just keep watching. Alright, thanks guys! Now, I am an IBD kid who has never had Remicade. It's been talked about. Sorry, Bruno is right here, and he is very needy. Talked about having Remicade, but I've never been in a bad point. At least, I mean, I was, but it required surgery, and then after that I was in remission, so I've never had Remicade, but I've given it a number of times. You guys know that I am a nurse at Children's Hospital of Philadelphia now, and I finally reached my 6 months there. So I have given Remicade quite a few times, and it's because I work on the GI unit. So I am seeing all the IBD kids, a lot of liver stuff, a lot of short bowel syndrome, a little bit of pancreatitis, so stuff like that. And I've given Remicade probably seven or 8 times. Maybe that's high. Let's say 6. I think I've given it probably around 6 times, which is a decent number for me only being there 6 months. I think it's because I can only take on the GI kids. That's the only side I've been trained on. We have kind of a double unit where we have GI and then we have endocrine kids. So diabetics, hypoglycemia. I don't really know what else they see there because I've never worked on that side. Only see the GI kids, and I think that's why I've had more than I typically would have if I had been trained on both patient populations. Now, because I work inpatient on a GI floor, I usually, when I give Remicade, it's to kids that are brand new, a brand new diagnosis of IBD. Pretty much just came out of a colonoscopy and they're putting in the orders for Remicade. So we have a few things that we prepare if we suspect that IBD might be what's going on with the kid who's having a lot of abdominal issues. We will do something called a PPD test. This is to see if the kid has been exposed to tuberculosis. So it requires an intradermal injection, which we kind of do an injection in the forearm. Usually it's right here. We'll do a needle that's, I don't know how to describe this, but it's kind of flat with the skin because our goal is to create a bubble underneath the skin. We don't want it going into the sub-Q tissue or like the muscle. We want it very superficial. So we kind of make this little bubble. We inject the fluid, and 48 hours from the time that we inject it, we check the site to see if there is a reaction, something called induration. And if there is a reaction, we know that the kid has been exposed to tuberculosis, and we need to look into it further. The whole reasoning behind this is sometimes people will have dormant tuberculosis just because they've been exposed to it, but they don't actually have the disease, and Remicade can cause dormant to turn into active, and we don't want that to happen. Now, often we will also do a chest x-ray to actually take a look at the lungs and see if there's anything going on. And you know that if you work in healthcare, we have to get a PPD, I think, yearly, and then if you have a positive PPD, you wind up having to get a chest x-ray to make sure you're not walking around with active TB. So that's why sometimes the parents and the kids are like, why am I getting this test? Because they haven't even had a diagnosis of IBD. But if they're kind of in line for a colonoscopy and an endoscopy waiting to get diagnosed, we do the PPD to try and quicken up the whole Remicade experience. If they come back from their colonoscopy and they say, yep, IBD, we don't want to have to wait the 48 hours from the PPD to start Remicade. We want to start Remicade as soon as possible so the kid can maybe get some relief as quick as possible. Now, if you don't know how Remicade works, it's a long infusion through an IV. Usually winds up being around 2.5 hours. I don't know if other places do it longer or shorter or whatever, but because we're giving it for the first time, we do it kind of at an increasing rate. We start off with a very small amount going in over a long period of time, and then increase it as we go on. Some things that we order beforehand are Benadryl and an EpiPen, just in case there is a reaction. Usually the reaction from Remicade will not happen until the second time, but we have it just in case something does happen. People do have bad reactions from it, and that's something I'm always like advocating to the doctor, you know, let's get the EpiPen, let's get Benadryl, let's get whatever we need just in case, because I have friends who have had very bad reactions. Not all of them, and they can be treated pretty easily, but we want to make sure that we have the medications in the right doses, already ordered, already at hand in case we need them. So once we've got those and we've got the Remicade order, it takes a while for them to make, so kids usually don't wind up getting it until the afternoon because I'm waiting for the pharmacy to make it up. I have no idea how that process works, so don't ask me. But what we wind up doing once the Remicade comes up, I'll set up the whole thingamabob. We have Remicade in one line, and then we have a saline flush. What we do is we have the saline bag like just hanging on the IV pole, ready to go. We use a special tubing that has, you'll probably know what I'm talking about if you've had any kind of hospital experience with IBD. Little IV tubing with the chamber, and it's where you see the fluid or whatever you're getting drip. In there's a little ball, so that way once we get to the end of the Remicade infusion, the little ball will actually stop and kind of block the line, and it'll make the pump alarm off saying, you know, empty bag or no flow, whatever it says, so that way there's no air getting into the line. At that point, when it gets to there, which usually we're in the room almost the full 2.5 hours or however long it takes, we're usually in the room most of the time, so we'll see this about to happen and we'll unspike the Remicade bag, come over to the saline bag, spike it, and our tubing, we just flush 40 milliliters. It's just what we do. So like I said before, we start off very slow and then increase as we go on. Before we start the Remicade infusion, we'll take a set of vitals, make sure that the IV is working, because that has been my experience a number of times. The IV has leaked or gone bad in the middle of a Remicade infusion, which is okay. We have to stop the Remicade infusion, get a new IV, which is a whole process in itself, because if you didn't know, I'm like one of the few nurses that has never successfully put in an IV, because at CHOP we have an IV team. I think it's so kids aren't afraid of us when we come into the room, because we're not the ones doing the IVs. We have special nurses, and they never have to see that nurse again unless they need a new IV, which is kind of nice. So if an IV goes bad in the middle of Remicade, it's just a whole ordeal, and to give the rest of the infusion, we start back off at the small rate and have to increase again. So it's just annoying. So I always make sure there's a great IV and there's no concern at all with it. It's just really annoying when it goes bad in the midst of the Remicade infusion. So I take the vitals before I start, then we start very small. I think we give like 10 milliliters over the first 15 minutes, and at the 15-minute mark, take vitals again, make sure nothing's changing, take the temperature, all of that. Another 15 minutes, increase the rate, vitals, and we do this for an hour. Every 15 minutes we increase the rate, take vitals again. Once we get to the hour mark, we're able to push it to half an hour. We increase the rate by quite a bit more, and then at the hour-and-a-half mark, take vitals again, and then 2-hour mark, increase the rate, vitals again, and from that point, whatever rate we're at, that's what we finish out the Remicade bag with. And once the infusion's done, do vitals, do the temperature, make sure the kid's great, and we're done. And I always get really excited when Remicade's done for the first time. I like, woohoo, we're done Remicade, congrats, you got your first infusion, it went great, because I know it's stressful for the kids, and it's something that this is not the last time they're getting it. This is going to be, you know, I think they typically do it every 6 weeks, sometimes more often than that. So I try and make it like, try and make them feel like proud of themselves because they got through something that's, you know, most kids don't have to do. Yeah, and for that first hour, I have to stay in the room just to kind of monitor the kid, make sure everything's good. I really enjoy this just because the kids have IBD, and then I start chatting with them and their family, and I get close to them. I really love giving Remicade. Most nurses, it's like, it's so stressful because you have to plan your whole day around Remicade infusion because you know that at least for an hour you're not going to be able to get away. But I like it, and it is a little bit hard to schedule all your other kids' needs, but it's great to get to know your patient too. So those are my experiences in giving Remicade. Like I said, I wish I could tell you what it's like to actually get Remicade. I'm one of the few people who has never had it and has Crohn's disease, so but I wanted to share it from the nurse's perspective. So maybe some of the things that you're like, why are they doing this, make a little bit more sense. But yeah, alright guys, I hope you enjoyed this video, and I will see y'all later. Bye. Hi guys, hi Bruno. Hello. Let's see. Bruno, can you stay? He's a good boy. He says the light's too bright for me. The light is too bright. Those ears. He's a good boy. Yes, my big boy. Right? Okay. Thank you. I love you.